Good morning, Wanda. How are you today? Good morning, Wanda.
Good morning. How are you?
Great. How are you today?
Doing well, thank you.
We'll wait just another minute or so, and then we'll get started with our webinar. I'll have to provide a little bit of background before we jump in, but I'm excited to hear what you have to say today and guide us through RADV. Certainly top of mind for everyone in our industry right now, right?
Oh, yes, it's definitely that first priority I think that everybody has, knowing what is going on.
For sure. So I think we're at the top of the hour. I'm going to go ahead and jump in. Thank you, everyone, for joining us this morning. Really excited to have you participate in our webinar. Our topic today is Don't Wait for the Notice, Preparing for RADV Audits Now. And our objective with this webinar is to just kind of provide some feedback and guidance. As you all know, CMS is shifting their focus on audits, and they're being much more aggressive. And I think what they're estimating is recoveries amounting to upwards of $4.7 billion. And it's certainly a large number, and there's a lot of anxiety, a lot of planning involved in preparing for the RADV. So thank you for joining us. I'm Chris Lally. I'm Vice President of Operations at RAPID. And our panelist today is Wanda Clayton. Wanda is RAPID's Director of Risk Adjustment, Coding, and Compliance. And previously, Wanda has worked at a health plan, led them through RADV audits. And then prior to that, she actually worked as a RADV auditor. So Wanda has unique experience of being both the auditor and the auditee, and she brings a wealth of experience to the conversation today. So the format will be a presentation. We'll go through some slides. Wanda will provide commentary. And we'll pause a couple times for some poll questions, and we'll leave time at the end for Q&A. So with that, Wanda, I think to begin, let's explore CMS's intensified audit strategy. Um, if our RAPID host could share the PowerPoint presentation, that would be great. Put it in slideshow mode. Excellent. Why don't you go to the next slide, please? Great. So, Wanda, to begin, why don't we explore CMS's intensified audit strategy and what it means for the executives involved? Would you like to go ahead and begin?
Yes, absolutely. Thank you so much, Chris. And again, good morning to everyone. And I want to also welcome you and thank you for attending this webinar. So let's go ahead and just jump right in because we have a lot of information that we want to talk about in a short amount of time. So the first thing I want to mention is when it comes down to these RADV audits, remember, RADV audits aren't just a compliance issue. They're a leadership priority that directly affects the financial stability in the organizational performance. So, what we're going to start out with is talk about the strategic importance here. So, how RADV audits actually impact the executive leadership. When we start looking at the enterprise risk management perspective, RADV audits are a high state process that can actually lead to substantial financial penalties and reimbursement adjustments. Proactive engagement will actually ensure that the stability in the risk adjustment revenue streams. We also have the executive oversight responsibilities. And when we look at that, we're looking beyond that compliance team. So when it comes down to the RADV audits, they actually require direct leadership involvement to ensure alignment with organizational strategy. It's also going to align with the reimbursement models and also those long-term financial planning. As you heard Chris mention a minute ago, and we're going to get into a little bit more and talk a little deeper about this, but what CMS is doing with actually going through and performing these RADV audits, I mean, they've always been there for many years, but the extrapolation is the key. That's exactly what is happening, and that's where it can actually hurt health plans. Then we look at the market competitiveness. So organizations that maintain an audit-ready documentation and proactive reconciliation will maintain a competitive advantage. CMS's scrutiny is actually increasing. Those that prepare early will outperform their peers in making sure that you maintain those financial stability and the operational efficiency. Now let's talk a little bit about the financial risk, those audit penalties in the revenue exposure. So executives actually need a high level understanding of CMS's enforcement trends and how those RADV audits are going to directly impact their bottom line. You have a significant financial implication when it comes down to these RADV audits. CMS's recoupment of overpayments could result in millions of lost revenue if the documentation gaps exist. The revenue integrity and forecasting risk, RADV audits are influencing the risk adjustment payments, which are actually directly affecting an organization's financial planning and reimbursement strategies. And then we have when we start looking at reducing those penalty exposures. Well, the goal here is to make sure that we help the executives institutionalize those pre-audit readiness. What is it that we can do to help you? That's the reason why we're putting on this webinar here today. We want to help you to be able to avoid those errors that can lead to clawbacks, fines, and also reputational damage. You probably don't ever think about that, but this can actually damage your reputation if you're not doing a good job and you have so many gaps, and it's going to cost you millions of dollars. And lastly, here, let's talk about the leadership accountability. How are we driving an audit readiness culture? So you have your CMOs, your CFOs, and your COOs. The CMOs need to make sure that you're ensuring that your clinicians and your coders actually adhere to documentation standards. Your CFOs, you want to make sure that you're establishing a financial safeguard and that operational model that can prevent the overpayments and the vulnerabilities. And then COOs, make sure you embed compliance workflows into the broader efficiency focus initiatives.
Wanda, are there any financial insights related to RADV audits that might be valuable to share with the audience?
Absolutely. So I think when we start looking at those financial impacts, one of the things you want to think about is that um, CMS has actually implemented an extrapolation method for the RADV audits, meaning that the errors that are found in just even a small sample can be scaled across your entire Medicare Advantage organization, your whole contract line of business. This is significant and it's going to increase the financial exposures. You also have where CMS has estimated that from 2023 through 2032, that the agency will recover an additional $4.7 billion from insurers due to the RADV audit findings. That's a lot of money that they're looking at recovering. And then we can look at the audit expansion. So we know that CMS has actually announced plans to audit, has announced the plans that they're going to audit all eligible MAOs annually rather than just saying that they're focusing on a limited sample. Before they were only doing a few that may be audited. Sometimes people could go years and never get an audit, but now they're saying everyone, all MAOs will be audited with a few exceptions there is. This will intensify the scrutiny and it'll also increase the likelihood of financial penalties. We also have where the OIG has found in recent audits that about 69% of the HCC payments were unsupported by documentation. This also is leading to significant overpayment findings. And then I think we also have where CMS is estimating that MAOs are overbilling by about $17 billion annually. Hence, here's the reason why the RADV audits are increasing. With some estimates also suggesting that this figure can actually be higher than 17 billion, but go as high as maybe about 43 billion. So there are some financial implications that we're looking at when it comes down to those RADV audits, Chris.
Certainly a lot to take in. Next slide, please. So, Wanda, why don't we examine some case studies that illustrate the financial impact of these RADV audits?
Perfect. So before we start with a couple of case studies, and I'll kind of mix those in here, let's talk about some of the industry trends. So CMS has moved from selective audits to annual audits, and this is across all eligible MAOs. We also have where CMS is estimating that the $4.7 billion in RADV audit recoveries are going to be through 2032, signaling that we have aggressive oversight on risk adjustment practices. Then we're looking at the extrapolated penalties. So the new RADV methodologies are extrapolating errors across an MAO contract, meaning that that small documentation issue can result into multi-million-dollar penalties. And then we also have the DOJ and the OIG who are also doing investigations. So this is increasing litigation in whistleblower cases, targeting those improper risk adjustment coding reinforcements that are needed for a robust audit preparedness strategy. Now, let's also, while we're talking about that, if you can proceed to the next slide, please. Let's look at case study one. In case study one, what I'm going to talk about here is how Medicare Advantage plans are facing extrapolated penalties. So these are real life scenarios. This isn't something that was just made up. So we have where the OIG has performed a RADV audit for payment year 2015 to 2016. The audit found unsupported diagnosis codes in a sample of about 200 members. The financial impact from that was that the audit initially identified about $480,000 in overpayment. But if you take that and calculate it and add in the extrapolation method that CMS is looking at doing, that $480,000 in overpayment has now turned to $27 million. I don't know about you, but that's a huge amount. I mean, 480,000 is already big for a health plan, but when you turn that 480,000 into 27 million, that's a lot of money that they're having to give away. So, with that being said, the key takeaway here is that that extrapolation method magnifies the financial risk, making those pre-audit documentation integrity essential. Next slide, please. So now we're going to look at another case study. And this case study is looking at a CMS audit of risk adjustment practices. So here again, the OIG has audited some diagnosis codes that were submitted by a health plan. They were targeting the high risk HCCs. The findings here is that there were 69% of risk adjustment payments that were unsupported by medical records, leading to significant overpayment findings. The financial exposure is that CMS estimated that the MA plans are overbilling by about $17 billion annually. And some are suggesting that this 17 billion is actually more in that it could be as high as 43 billion. Again, when we look at our key takeaways here, we're looking at that organizations must institutionalize that audit readiness strategy. We want to make sure that you're preventing those revenue loss, the reputational harm, and also any operational disruptions that may happen. Now, if you can go back 2 slides, back to the other slide that we were looking at originally. I want to continue on that slide and look at some of the financial, so we were talking about the financial risk there. So want to look at just saying that for that executive level compliance strategy, we want to look at integrating RADV audit preparedness into that broader governance framework. So let's look at what the roles will be when we start looking at leadership accountability. We have, again, that the CMOs need to ensure that the clinical documentation integrity is there, that the CFOs are establishing that audit-driven financial safeguard, and then the COOs are actually embedding the RADV readiness into a workflow efficiency. Okay, if you could proceed 2 slides up, please. Next slide.
We have our first poll question. So if you look in the chat, our moderator will add a poll question. We'd like you to enter your responses in there. And at the end of the presentation, we'll provide feedback on the responses we get from the polls. Very good. Can you advance to the next slide? Thank you. Excuse me. So Wanda, we've covered some of the risk. Now let's dive into the solutions. What proactive steps can executives take to ensure audit readiness?
So one of the steps that can be taken is we can look at the data accuracy as being a competitive advantage. So with this, let's look at when you look at your key executive considerations, look at the financial implications. CMS audits can actually result in clawbacks on payments due to the documentation errors. And with that being said, you have where the accurate coding is going to mitigate the financial penalties. We have the risk scoring in the payment integrity. And with that, we're ensuring that HCC coding actually will accurately allow the MAOs to maintain an appropriate reimbursement while avoiding those CMS scrutinies. And then we have market competitiveness. So the plans with high compliance scores are going to gain better payer relationship and consumer trust. So this is going to improve their long-term positioning. Then we have where we have the operational streamlining and the cross-department coordination. Here, again, we're looking at those roles that we were talking about earlier, your CMO's roles, which is going to be strengthening the clinical documentation practice. Here, you need to make sure you're driving the physician education on proper documentation techniques. You want to make sure you're reducing the HCC coding error. So make sure you're training. You have all these different training initiatives going on, not just for the providers, but also for your coders. You also want to ensure that the physicians understand what the CMS compliance expectations are, so that when they're making those documentations, when they're documenting in their chart notes, that they can make sure that it is compliant and it is meeting the expectations that's needed so that you are able to capture those conditions. Then when it comes down to the CFO's priority, we want to make sure we're establishing those audit-driven financial reserves. So that way you're prepared for the potential CMS recoveries that may happen. You need to be tracking the RADV audit exposure rate across different pools. See what everybody else is doing. See how, what's happening with those RADV audits and where others are landing. And then you need to forecast your financial scenarios. Always have, again, going back to those financial reserves, if you're forecasting your financial scenario, then when those RADV audits come up, you can have an estimation as to what it is that you may have to end up paying back. And then when it comes down to the COOs, you want to make sure that you're embedding that audit readiness step into the standard operational workflows to prevent those inefficiencies. You want to enhance your interdepartmental coordination to create that unified compliance strategy, not having where your departments are all silo. And then you want to leverage that technology solution so that you can streamline reporting, tracking, and then audit management. Next slide.
So one to kind of expanding upon what you were just talking about, obviously technology is transforming compliance frameworks. Can we talk a little bit about how AI and ERP solutions can be utilized to reduce audit risks?
Yeah, absolutely. So when it comes down to those ERP systems, if it can act, it's great to be used to integrate compliance workflows, ensuring that the audit readiness is embedded into daily operations. So the key capabilities to be able to use this for RADV audit readiness is that you're going to have real-time documentation prompts. You can integrate EHR solutions, provide real-time guidance to clinicians, and ensure complete and defensible documentation. You also will have that historical data validation and risk gap closure. So, some type of ERP solution can analyze previous patient encounters, flagging for those missing risk adjustment codes. And then built in CMS compliance logic is something that can be used as well. So, a modern ERP solution will automatically update those coding rules based on CMS HCC model changes. That way you can stay up to date and make sure that you're always using the latest model that CMS has come out with. And you can ensure that audit resilience. So, with that, I also want to give you another little case study here. And with this case study, what I'm looking at is this was an MAO who implemented AI um, as a risk adjustment software tool. And this was done so that they can enhance the audit preparedness. The results that happened from this was that they were able to reduce the documentation error by 35%. Why? Because that AI driven prompt ensured complete medical records before submission. They were able to lower their audit penalty exposure by $12 million. Why? Because predictive analytic flagged high risk coding discrepancies and it allowed for proactive corrections. And then they were also able to improve their compliance scores by 22%. Why? Because the automated validation ensured alignment with CMS audit expectations.
I'm curious from the audience, any of you who have worked in or with ERP or AI systems, what are some of the technologies your organizations have used to successfully improve documentation accuracy? Not necessarily relating to RADV only, but just in general. We're always curious to understand what your experience has been. So if you can type any feedback in the chat, we'd love to see it and share it with the rest of the group. Our next poll question, if you all take a moment just to review the poll and provide your responses, we'd appreciate your feedback. What is the biggest challenge in audit preparation for your organization? Documentation accuracy, financial contingency planning, or technology integrations? We'll give you just a moment to answer that question. And one, we have a couple of questions that have come in through the chat while we've been speaking. One of the questions is, can you provide some examples of what the high-risk HCCs are?
Yes, absolutely. So when it comes down to those high risk HCCs, I don't know if you've looked at the OIG playbook that's out there, but the OIG playbook has a lot of the high risks that they're concentrating on. And CMS also kind of uh, goes along with that and uses that as high risk. There are some additionals that may go with that, but you're looking at things like your cancer, your stroke. Um, those are some tops as far as the high risk. Um, uh, Diabetes isn't really considered as a high risk, but uh, MIs is another high risk. And I think PEs also fall on that list. So those are some of the examples of what is considered as the high risk.
And so with those ones, do you find that typically the challenge is with the um, on the coder side, being able to accurately identify and code for those properly? Or is it more a function of just improved documentation or on the part of the physician, or do you think a combination of both?
I actually think it's a combination of both because it starts with the provider. And a lot of times the provider is going to make the documentation notes and state exactly what they feel, or they're looking at the evidence that they have of what the patient may have. Sometimes it's not even always saying that it's the evidence, but sometimes the provider is saying, hey, like take stroke, for example, this patient has come in and they're coming in for a follow-up of their stroke. Well, just because they're coming in for a follow-up, the stroke is not active at that time. That stroke has already happened. Then we look at cancers, and cancers again is one of those of, even though the patient may have finished cancer, or maybe the patient may even just be at high risk for cancer. Again, we don't want to code that the patient has cancer because the cancer is not active. Again, we need to wait until that cancer is active in order to be able to code it. But then when it comes down to the coders are now having to decipher what the providers are actually saying. They're trying to look through the notes, they're trying to make that determination of, okay, they're saying they had a stroke, but they didn't give enough information here. Did this stroke just happen today? Did they have to send the patient, especially if it's an outpatient, did they have to send the patient out on a gurney and send them to the hospital because the stroke happened in their office? Or looking at the cancer, they may still be on treatment, but with that treatment, the question is uh, are they taking the treatment prophylactically? How long have they been on treatment? So these are just some things that are sometimes missing, and it makes it harder for the coder to decipher on whether or not this is an active condition or not.
Great, it's great feedback. I think our team has the poll question responses all collected. Would you like to share the poll feedback, please? Question number one, how concerned is your organization about RADV audit penalties? 47% were very concerned, 53% somewhat concerned, and nobody is not concerned. So kind of what we would have expected, I think, right? So there's obviously it's top of mind for everyone. Can you post the results for the next poll question? While we're waiting, Wanda, here's a poll. What is the biggest challenge in audit preparation for your organization? Documentation accuracy, 74%, financial contingency planning, 11%, technology integration, 16%. The documentation accuracy, that one of the things I thought of when you were talking about high risk codes is that um, I think we're at this juncture now where over the last 5 or 10 years, there's been a much greater emphasis placed on physicians by some organizations that providers do their own coding, whereas others are more focused on removing that burden from the providers and having coders be the coders. What do you think, or do you have an opinion on what the impact might be in RADV auditing for organizations where the providers do a majority of their coding, and perhaps they don't have, um, you know, CDIs or auditors in the background, kind of watching and editing, auditing what the providers are doing. What do you think the impact may be that we'll find from a RADV perspective?
Well, I think when it comes down to the RADV, it definitely has a high impact on what the providers are doing. This is the reason why it's so important that those health plans actually get out there and educate their providers. They do need to have a provider educator because sometimes some of the you know, providers out there may have heard of risk adjustment. Some of them have not. Some don't have the concern. Some are looking at that they feel like it's just a way for the health plans to make money, and why should they care? So it's great for the health plans to get out there and educate those providers and let them know why they should care. Let them know why it matters to them, and then educate them on what their documentation looks like. I know you mentioned about the coding, Chris, but keep in mind that when it comes to the providers, they didn't go to school for coding, and that's not something that is top of their mind. Top of their mind is taking care of the patient. So instead of the health plans talking to the providers about coding, they need to actually talk to the providers about documentation. As long as they talk to them about the documentation and what needs to be documented, or the information that they need to include in their documentation to make sure that it's clear, it's concise, it's complete, then it'll be better for the health plans in order to be able to abstract the correct codes that need to be um, abstracted in order to be able to submit that. So I don't know if I really answered your question. I think I kind of went on a different wavelength as far as being able to answer it, but I think that is the way to look at it, more or less, of saying that the providers, are they documenting, are they coding it incorrectly, which is causing a problem with RADV. Does that make sense?
It does, and I think it's a good segue. One of the attendees had mentioned in the chat that they're querying the provider at the point of care, and certainly point of care pre-visit solutions are in quite a bit of demand. On the part of the provider, there's a great sensitivity, of course. You don't give the providers another button to click or another application to utilize. But do you think the like a byproduct of the emphasis on RADV is going to maybe remotivate or cause organizations to think more thoughtfully about giving providers more feedback, more information they can act upon at the point of care, so that they're ensuring that through the efforts of CDI or chart validation staff members, they're getting data that helps them plug gaps, helps them identify maybe things that are being overlooked that they can act on.
Yeah, absolutely. And I do think that that's going to um, make a difference. And when it comes down to it, I think the biggest thing is number one, when it comes down to the health plans, do you actually have the capacity to query a provider? Also, on the provider end, do they have the capacity to be able to answer all of the queries that are coming through?
Got it. Great feedback. We have a good question. One of the audience members has asked, how do you foresee the role of retrospective risk adjustment shaping up for both full risk providers and plans? And how does that complement prospective risk adjustment?
Well, when it comes down to the retrospective risk adjustment shaping, I think that it is going to shape both full risk providers and the plans, because with that retrospective, I'm getting ready to kind of backtrack on what I'm getting ready to say, but with the retrospective audits are being able to help so that you can give the providers information as to what they're doing wrong or how they can improve. Let's not look at it as what they're doing wrong, but how can they improve? What can they do with their documentation? And then this is what how it's going to help the health plans. But at the same time, I'm going to throw in here when it comes down to that prospective, your difference there is your prospective is going to be closer to your real time versus your retrospective is so far away. By the time you're done with a retrospective audit and you get all the results and you're ready to even take that and go to your provider and let them know what you've come up with and give them information on improving, you have 2 years that have already passed by. And in that 2 years, the question is, have they continuously been making those same errors or things that need to be improved, which is still lacking and not allowing you to be able to pick up the appropriate conditions that need to be captured? Or are we looking at that in that 2 years, maybe they have improved. Maybe you were already sending out, that provider educator and the improvements have happened. So now when you go to talk to the providers about what they did 2 years ago, they're saying, I don't do that anymore. I don't document that way anymore. So that's the way I look at it. That says that when it comes down to your perspective, um, I think it will complement your retrospective quite a bit. And it's probably one of those that if you're able to do prospectives, definitely over retrospectives.
And, one of the things I'm always sensitive to is that in a retrospective audit project, there's so much data you collect, data about codes, about HCCs or XHCCs, providers. And if all you're doing is providing data about the data, it's not really that helpful, right? I think the important thing is to take that data that you get through the retrospective audit and slice it up in a way that's usable and understandable for people that provide education back to the providers, for people that provide education to the finance folks. And there's just quite a bit of information you can pull from that that is actionable that you can use for training purposes, whether it's providers or coders. I think that's the key thing, right? Is that sometimes we get lost in this giant sea of data, and it's hard to see really what the most important elements are. So I always think breaking it down into the two or three things that have the most impact or the most value for the plan, for the providers, and for the coders as well. I think it's important that if you're using an in-house coding team, an employed coding team, or a vendor, that you provide feedback to the coders and auditors on what you're sensitive to and what you think needs to be. Certainly, codes that require a higher level of attention to detail and scrutiny, just to make sure they are supported by the documentation and the evidence found in the documentation. Okay, we're almost out of time. Just one last question for you, Wanda. How should executives institutionalize compliance culture across all the departments? You have, finance, operations, quality, coding. What is the key there to kind of eliminate those silos and adopt a plan and a culture organizationally that can be supported and thrive?
Sorry, I went on mute because I had to cough. So I think that executives should actually start aligning compliance goals with their financial and operational priorities. They need to make sure that they ensure those audit readiness is a leadership-driven initiative rather than just being a reactive compliance task.
Great. Well, thank you for that. I think we're right at time. Are there any other questions from anyone in the audience who would like to raise them? In that case, Wanda, what are the key takeaways for the leadership teams?
So the key takeaways for those leadership teams is we want to make sure, again, remember what we talked about on what the CMOs, CFOs, and COOs, what you need to prioritize and what you need to prioritize starting today. Again, those RADV audits, they've already started. 2018 is completed. 2019 is in process right now, and 2020 and on is on its way. It's coming. Make sure you institutionalize those best practices without overwhelming your team. Again, this is going to be a lot. When you start talking about every year that there's going to be, that every MAO is going to be audited for 2020, 2021, 2022, 2023. That's going to be a lot because right now you don't know how soon, but I have seen that for 2019, they have definitely cut the audit time by half. You only have, for the most part, 90 days to complete this audit. And if you end up with 200 members that you're going to have to, enrollees that you're going to have to audit, that's going to be a lot that you're going to have to try and get done in 3 months versus 6 months. And then secure those buy-ins across departments for sustained compliance readiness.
Great. Well, thank you, Wanda. Really appreciate your feedback and all of your guidance today. I think it was really helpful. I learned a lot in the process of preparing for this and today as well. We will share out a copy of the presentation to all the attendees. And if you have questions for Wanda, please feel free to reach out to her. I think, Wanda, you'll be at HFMA upcoming, right? So anybody can visit with you there if they have follow-up questions and they're attending HFMA.
Yes, absolutely. And I look forward to seeing anyone.
Well, thank you everyone so much for joining. We really appreciate it. I appreciate the questions. And again, if you have any follow-up items, please feel free to reach out to us. Thank you very much and enjoy your weekends.
Thank you, everybody.